good evening to all the aspirants present here. The topic for today is thyroid disorder, and the faculty that we have here is Dr. Tirthankar Chaudhary. He is a senior consultant, diabetes and endocrinology at Apollo Multispeciality Hospital. Thank you, sir. You may go.
A very good evening, and I thank the organizers for inviting me. Today we shall be talking about a very common disorder that we all come across. Now the problem is that I've been asked to speak on thyroid disorder, which is a huge subject. So I'll try to just say what is clinically relevant because we all are qualified doctors. So let us think what is our thyroid is. As you all know that it is a gland about 12 to 20 grams in weight in the anterior aspect of the neck, and it is attached to your trachea with a Berry's ligament. It has got two lobes and an isthmus. And you also know that these thyroid glands have got follicles where iodine uptake happens and formation of thyroid hormone is seen. There are also parafollicular cells that produces calcitonin, something to do with the calcium metabolism. You also know that there is closely attached parathyroid glands, secretes parathormone, and they have also very important role in calcium metabolism and bone metabolism. With this short introduction, let me tell you that thyroid disorders in India is pretty high. You have got a hypothyroidism is 3.9%, hyperthyroidism 1.3%, goiter in 23%, Hashimoto 7.5%, and thyroid cancer 1.1 to 0.2. Now remember, we have not given you the data on subclinical hypothyroidism. There is actually a huge number of patients who are actually in the range of subclinical hypothyroidism. Now, when you sit in the clinic, when you see a patient with hypothyroidism, why it is so important that you need to identify the disease? It is important to identify this disease because it leads to morbidities. So therefore, we must make sure that I'm seeing some lines coming in here and there. So basically, what you need to do is to identify the disease so the patient does not have problem. We also know that the thyroid disorder can lead to adverse comorbidities and cardiovascular outcome. Severe hypothyroidism, for instance, look here, if you have got severe hypothyroidism, is someone else trying to do something on this? Because I can see a lot of lines coming up on the screen. Organizers, so severe hypothyroidism may present as a myxedema coma. So hypothyroidism is a state of inadequate hormone production. And an advanced and ultimate form of this is a myxedema crisis, which is hypothermia, encephalopathy, seizure, and lead to a life-threatening condition. Hyperthyroidism is another aspect where excess hormone is produced, and normally there are many forms of thyrotoxicosis. Hyperthyroidism is a state of excess hormone production, but thyrotoxicosis just means excess hormone in the blood. That can happen as a result of inflammation, decoadvanced thyroiditis. So therefore, it is very important to understand whether you are getting an inflammation and the stored thyroid hormone is coming out in the system, or you are producing more thyroid hormone. So if you get a thyrotoxicosis, the treatment will differ in the two. Therefore, you must know that which one you are dealing with. Now, the burden is important because we need to know what is impact of individual with thyroid disorder. In general, patients with multimorbidity, two or more, have a worse quality of life. So if you have got more comorbidities, whether hypertension, diabetes, or cardiac, if you have got a thyroid disorder on the top, then you'll have a worsened quality of life and you'll have more complications that can come. So it is very important what do we do? Screening and diagnosis is important. If you see a patient of thyroid, a patient and you are suspecting a thyroid disorder, it is not possible to screen everybody, but you must screen for people coming with the symptoms of hypothyroidism and of course in pregnancy. These are and patients with atrial fibrillation. So if you see some, then you must of course investigate. Anybody with the signs of thyroid disorder, gaining weight and lethargy, then you can advance state, you can have edema, you can have constipation, you can have dyspepsia. So how do you screen a patient for that? TSH is very important that if you do a thyroid test in a patient, one of the way to do TSH is actually very important way of screening a patient for thyroid disease. Now, you can have either low TSH, you can have high TSH, or you can have a normal TSH. If you have a normal TSH and no problem, then you can exclude thyroid dysfunction. But if you have got a high thyroid TSH, then the possibility is that the FT4 will be low. Or FT4 will be normal, as it happens in subclinical. Or you may get TSH high as well as FT4 high. That may be central or pituitary origin hyperthyroidism by TSH-OMAs. Or you can have interference with drug, etc. So it is very important that you understand the relation between TSH and T4. You might also see that if the TSH is increased very much in hypothyroidism, then you can have a higher prolactin level because the TRH that stimulates TSH has also has an effect on stimulating increased prolactin release. If you look at the low TSH, then you know that you are probably having excess hormone. If you have got a normal FT4T3, it can be subclinical. If you have got FT4T3 is low, then you wonder, is it a hypopate? Because if you have got a central low TSH and FT4T3 low, then you wonder about non-thyroidal illness. You think of sick thyroid syndrome, or you think of situation where FT4 TSH is high, that is the primary hyperthyroidism. So this slide is important for you to understand that what is the main cause of your TSH. So relation between TSH, FT4 and T3 is very important in trying to understand. Now, once you have got hyperthyroidism, it is important to do a technetium scan because the thyroiditis will have no uptake or less uptake. A hyperthyroidism will have an increased uptake. And if you are suspecting an autoimmune disorder of Graves' disease, then you can either have ophthalmopathy or Trab will be raised. So these are the subtle things you should know about thyroid disorder. The unique challenge in Indian thyroid disorder is that easily available TFT and probably sometimes not so much standardization can give rise to huge amount of subclinical hypothyroidism. And these are in rise because obesity increases TSH, age increases TSH. So if you see somebody is 70 and TSH is 6.5, I would ask you to wait. Hang on, don't try to treat it. But the same in a pregnancy you'd like to treat. A growing up children you'd like to treat. A symptomatic adult you'd like to treat. Now, ultrasonography easy access is another problem. Even if you have got a small nodule, it catches. And then you are into the rhythm of investigation. Remember, a thyroid nodule of less than 1 centimeter usually doesn't make much difference or sense. Anything above 2 centimeters should draw your attention. Rapidly enlarging nodules should attract your attention. Above 2 centimeter nodules should undergo an FNS. Anybody over 4 should have a surgery. Size of a thyroid nodule unknown alone is an indicator of risk of malignancy. So therefore you should, it is unclear with the following, the guidelines are also not very clear about how much to treat. Now, how do you treat a hypothyroidism? You treat with levothyroxine. Now, basically, normally levothyroxine usually does the job. If you have got TSH above 10, then you need to treat it. If you have got a TSH less than 10, if it is anti-TPO is raised, probably you need to treat. If you have got a pregnancy thyroid TSH less than 10, you need to treat. If you have a growing children, you need to treat. But if above 10, then everybody will treat. That is the consensus. Now the question of when do you add T3 tablets? As you know, nowadays it's available in market. You have got T3 tablet. When you give T4, you know the T4 acts on receptors. You have got 80% circulating thyroid hormone is T4, and the 20% is T3. Now T3 is the active hormone. The T4 goes to the periphery, converts into T3, and then it has got an effect on the metabolism. Sometimes what happens, T4, T3 conversion in the periphery may not be so good. I have got some patients who were taking levothyroxine or eltroxin thyronome in the tune of 200, 300, and the TSH still in the order of 30, 40, 50. I started on Leoma T3 tablets along with levothyroxine, and their thyroid function test came down to normal. Therefore, there is some peripheral problem in conversion. You also know that there are receptors of thyroid hormone. You have got thyroid hormone receptor 1 or TRB 1 and 2. So you have got receptors. They also play a part in the process of action. Try to start a low dose and go up before you start on a high dose. Somebody who has got ischemic heart disease, you should be very, very careful in starting levothyroxine. Now, if you look at the evidence, of thyroid disorder, then hypothyroidism guideline by American Thyroid Association, based on the evidence-based recommendation, patient with primary hypothyroidism, TSH more than 10 should be treated. TSH 4.5 to 10, as I told you, depends on many factors. Growing up children, symptomatic adult, pregnant women. Screening should be performed in patients above 60. With age, TSH increases. T4 monotherapy is the treatment of choice, but there may be some patients who may need both. Now, in adult patient, target T4 is something around 1.5 to 1, something around 3.5 to 4. And you start something around 1 microgram per kg body weight. So that gives you around 70, 80 or 100 micrograms. In elderly, go slow. Try to start on 50 and try to increase the dose over a week or two. Monitor your replacement therapy in 6 to 8 weeks. You don't try to go gung-ho and trying to treat, because it may precipitate atrial fibrillation or even ischemic heart disease. Government of India hypothyroidism guidelines has got given you, it tells you that all newborn infants should be tested, pregnant women should be tested, those with strong family history should be tested, like somebody comes with a vitiligo. Those with an autoimmune disorder and type 1 should be treated because they have got autoimmunity anyway. Autoantibodies in the blood. Depression, dyslipidemia, infertility can be, and other that constipation can be another one. Menorrhagia can be another one. So, Government of India hypothyroidism guidelines. Can you keep your speakers in mute, please? Now, Government of India hypothyroidism guidelines tells you LT4 treatment to be built up gradually. Don't try to give in one go 100 or 125. Rather start with 25 or 50 depending on the patient and gradually build it up. Monitor the thyroid initially 6 weeks to 3 months, and then you can do it once in 6 months, even yearly if things are steady. Emerging therapies and personalized treatment approach. Now people are talking about L4 plus LT3. There's T4, T3 treatment. As I told you just now, that I have got some patients who are struggling with a very high dose of T4, and I added T3. And then, so I want you to do it very individually. I don't think that can be a policy of treating all patients with both. 20 prospective RCTs has compared. Combination is safe and effective provided you choose the right patient. And if your TSH is normal, and if you are using only one, that is levothyroxine, I would recommend that you don't start the T3. T3 should be used in the hands of an expert. Subclinical hypothyroid is the minefield where we should discuss, because now there is increasing evidence that even in subclinical hypothyroid, it can adversely affect atherosclerosis and cardiovascular outcome in long time. So you definitely treat subclinical in pregnancy, symptomatic adult, growing up children, and anti-TPO positive subclinical hypothyroidism, or even in Farz perioperative. However, it is better to repeat them, do an anti-TPO antibody, watch the changes, and then start treatment. Now comes hyperthyroidism. Hyperthyroidism is slightly more challenging than hypothyroidism. Here what happens is, the word hypothyroidism is not right. I would say in clinic you will see thyrotoxicosis. That is excess thyroid hormone and TSH supply. That can happen due to hyperthyroidism, or that can happen due to thyroiditis. It can happen due to painless thyroiditis, or it can happen due to painful thyroiditis. Painful thyroiditis is a treatment with steroid, as you know, in the more severe ones, decoadvanced thyroiditis. If you do a scan, it will show no uptake. TRAB will be negative. But in hyperthyroidism, there may be ophthalmopathy. TRAB may be raised and there is increased uptake. So it is very important to identify, because treatment of thyroiditis is totally different from hyperthyroidism. Now, we have seen that something around 1 to 2% prevalence across of these diseases. And it is important to identify. Patient comes with weight loss, heat intolerance, hyperdefecation, tremor, palpitation, even atrial fibrillation. So you must treat this. How to identify the etiology? As I told you, it is very important to identify whether you are dealing with a patient of hyperthyroidism or thyrotoxicosis. Here, you measure TSH, see what the TSH levels are, then do FT3 and T4, look at their levels, do the technetium scan and see whether the uptake is high. It can be nodular, or it can be thyroiditis. There is no uptake. Toxic nodular goiter, just 1 point of is taking up the radioiodine or technetium. You can do radioiodine ablation and this will go. So solitary toxic adenoma, or this one, Graves. Then if you do ultrasound, you can see some difference in this may be the scope of this, but you can still see how nodule is a solid thing. in case of adenoma, whereas otherwise you have got reflecting echoes. So these are important to you usually take the help of radiologists, but you can see that how you can understand the difference. So increased uptake, hyperthyroidism. Less uptake, thyroiditis. Neomarcazole and methimazole is a treatment, or PTU is a treatment for hyperthyroidism, not for thyroiditis. Now, management of hyperthyroidism, you can do medical. Radioiodine treatment, you are cautious in patients in whom there is ophthalmopathy. Pregnancy, thyroid eye disease, TED is eye disease. If you have got large goiter with hyperthyroidism, then surgery is a very good choice. If you have got a relapsing hyperthyroidism without eye signs, TED, thyroid eye disease, RAI would be good. Even if you see a young lady with hyperthyroidism, you may think of RAI treatment because this lady may get married and plan pregnancy. And then it becomes a challenge to use drugs in pregnancy. If you do RAI treatment, you have to give at least 6 to 1 year gap before she plans pregnancy. Remember, radioiodine treatment is better in definitive treatment of the problem. So medically, you can use tablets. Now, if you have got a pregnancy, in the first trimester, 12 weeks, you tend to use PTU, propylthiouracil, because methimazole, carbimazole has got a risk of side effects. One of them is cutaneous tarda, where there is no skin development. It is not very frequent, but can happen. PTU is safer, but it can cause hepatic problem. But once first trimester is gone, you can switch to methimazole. But by the way, that's why I said the best way is to treat and sort out thyroid in a definitive way before someone plans pregnancy. You will see some people arrive to you with hyperthyroidism and then you have no way, but you have to treat it. Now, when you are giving a beta blocker for symptomatic relief, watch out for asthma. So these are, and you treat for 1 to 2 years, 50% goes in remission, and they may come back again with a relapse. Now, how much do you treat them with? Well, normally you start anything between 20 to 60, both for methimazole and carbimazole, and then you adjust, fine tune. And there is evidence that if you drag your neomarcazole or methimazole treatment for a longer time, chances of relapse is less. Thyroid eye disease is a different chapter altogether, and sometimes it can be very
Excuse me,
obscure.
sir.
Now, sorry?
Sir, your voice is breaking, sir. It's difficult to hear.
Can you hear me now?
Yeah. Sir, you told about pregnancy, no? Propylthiouracil versus carbimazole. Can you repeat that, sir?
No, I said that when somebody is pregnant, the problem is that you have got 3 ways of treating. You don't want to take up surgery. Sometimes in second trimester you can. If you are planning to take up RI 131 treatment, you have to do it much before the pregnancy, at least 6 to 9 months before. You should have a gap. If you want to take tablet, then first trimester, if you have to use a tablet, then PTU is better. In the second and third trimester, you can use carbimazole. Now you come to the rationale of management.
Okay, sir. Thank you.
Now, why lower maintenance dose? Now, we know that as the longer you are giving your carbimazole or methimazole, slowly you are destroying the ability of the follicles to uptake iodine. So the longer you do it, the longer is that process impaired and the thyroid hyperthyroidism is corrected. Now, hypothyroidism may supervene because it's very difficult to understand the exact dose. That's why we titrate. Every 4 to 6 weeks, call the patient in hyperthyroidism and try to adjust the dose depending on biochemistry or thyroid parameters. Anti-thyroid drug regimen for treating Graves. Now the problem is TED, that is thyroid eye disease. But otherwise, hyperthyroidism is treated for 1.5 years to 2 years with methimazole or carbimazole. We say methimazole because carbimazole has to go into the body, metabolize to methimazole before action. So it is better to give them methimazole, available in the market as Methimaz. And you start with 10 milligram TDS, 10 milligram BD, or 10 milligram QDS and adjust. Try to drag on the treatment for 12 to 18 months and then you wait for relapse. 50% will go in remission. Now, what is the rationale behind the long term? What happens is the capacity of interfering with the immunological abnormality involved in Graves' hyperthyroidism decreases. So thyroid peroxidase block the iodination of the tyrosine is decreased if you give a long-term methimazole. So as you know that they inhibit uptake of iodine. That's why long-term hopes to take a long-term remission. Now rationale behind 12 to 18 months, as I told you, 50% patient will have remission, 50% may come back with a relapse. And then if there is no contraindication, RI 131 treatment, or if there is a swelling or goiter, a surgical treatment is best. And you also see the TRAB levels. If the TRAB, TSH receptor antibody levels go down, then you know that there's good news for your remission. What to expect during management? Watch out for agranulocytosis, rashes, sore throat, and other than that, management of thyroid parameters. So normalization of T3, T4 is our watchword. We must make sure that it is done. What to expect during management? TSH may remain suppressed for several months. So it is not a very good parameter all the time, but is an important parameter. But once it is euthyroid, that if you find T3, T4 is normal and TSH is still suppressed, then you can slightly reduce your neomarcazole or methimazole you are using. You have to be very careful because you want to correct the hyperthyroidism totally. Clinical data suggests that TSH recovery occurs within 6 months after treatment. So it may take a bit longer time than you think. And there are some controversies. How long patients should be treated? We have agreed to 1.5 to 2 years. They say, does the dose influence the remission? No, it's the duration that does. Quicker the remission, better is the outcome. Agreed. Does the co-administration improves? No. There are talks about block and replacement. If we give 60 milligram of carbimazole and 100 milligram of levothyroxine, does that work better? No, I think that was practiced at some point, but is not popular. Does presentation of antithyroid drug disease chance of storm? You should be careful in antithyroid drugs because when you are doing that, after therapy, radioiodine, sometimes the cells release thyroid hormones. So patient should be on beta blocker. So adverse event profile, as you know, agranulocytosis is the worst. PTU has got hepatotoxicity more. And then minor adverse effect of pruritus or diarrhea, things can happen. But normally, they are pretty safe, I can tell you. Some of them have come back to me with rashes. And mostly they happen quite early in the first 1-2 months, or maybe in weeks. They have fever, pharyngitis, and you have to check the RBC and CBC to make sure they are not going down. RAI and surgery, as I told you, surgery for the goiter And radioiodine, if there's no ophthalmopathy and you are trying to do radioiodine, then that is a very good way to do it. Remember, it takes some time to for the remission. So, but you can give it, and once they come back slowly, the things get better. Now, comparison of treatment, I think this is not a very good comparison because it depends on the individual. But still, antithyroid drugs are more acceptable. They have got some potential side effect, but normally not a problem. Radioactive iodine, as you know, that it can cause a bit of ophthalmopathy, and they can achieve cure in vast majority, and normally does not cause much of a problem. It can cause some excess thyroid hormone release. Thyroidectomy is very effective because it takes the very expressing tissue, so it causes a permanent hypothyroidism or treatment. Symptomatic management, of course, you do propranolol beta blocker. You can use them, and cardioselective beta blockers. You can use them, but be careful that patient is not having asthma. Thyroid nodule is another important aspect, and that may be a topic of a huge topic for another class. What happens is if you see a nodule, I told you, first see the size. Then you ask the history of development, how quickly it has come. If it is more than 4 centimeter clinically, take it out. Do an FNSC ultrasound, take it out. If it is 2 to 4, do FNSC. If you get something, take it out. If you don't get anything, then also probably you can either watch once or twice. Better to take it out. For very small ones, you may wait and watch below 1 centimeter, but if they are rapidly increasing number of size, take it out. Thank you very much. I thank the organizers for inviting me, and I also thank for helping me with some of the slides.
No, sir, in patients with critical illness, like recovering from septic shock or patients
Yeah, I
who are
tell
on
you that.
mechanical
I
ventilation.
briefly mentioned I was taking of sick thyroid syndrome. Remember that if normally we don't have the facility of reverse T3. Remember in critical ICU areas and sicky patients, you should take it with a pinch of salt. Because what
Oh,
happens is when you do the thyroid test, usually your TSH and FT3 are suppressed and T4 is high. So the best way to do it to find out whether the patient has hyperthyroidism is A, look clinically how the patient presents. Number two, if we could do reverse T3, RT3, then that it clinches the diagnosis. But in
oh,
our normal thing, if patient is totally asymptomatic and you have got a sick thyroid syndrome, you wait and watch, let the patient recover. But if you have got tremor, if you have got hypothyroidism, if you do a technetium scan, they're raised, and all these things, then of course you need to treat.
oh,
Thank you.
thank you, sir.
Sir, one question. Sir, one question.
Yeah.
Sir, why hydrocortisone used in myxedema coma?
See, when there are two things. One is you get a thyroid storm and you get a mixed edema as another life-threatening condition. Even if you use a steroid, because when these very, to be honest and practical in your emergency territory, when you come across these very serious patients, sometimes it becomes a very difficult to understand. What happens is adrenal overlaps with your thyroid function a lot. So you will do no harm if you give them steroid. However, you have to see that whether you have got a diagnosis clearly done or not. Because you, so one more thing happens is if you have got a severe hypothyroidism, you know the blood pressure is low, blood sugars are
Yes.
low, your there may be postural hypotension. So you will do never wrong by giving steroid. So my thought is that if you have diagnosed it, You may use an RT Rice tube also to push in 300 to 500 levothyroxine along with T3. You can, of course, give steroid, there is no problem. And often what happens is that there is associated adrenal insufficiency. So
Right.
if you are treating somebody with lot of levothyroxine and you are not backing up with the adrenal reserve, then there may be a problem. So yes, you can give. The answer is yes.
Sir, I have one question.
Yes.
Hello, nice to see you, sir. Uh, uh,
Yeah.
I am Dr. Ghoshal. The
Okay.
question
Yeah.
is thyroid scanning mandate in all hyperthyroid patients? Number one. And what is the management of subclinical hyperthyroidism?
There are two questions. The first one is if you have got hyperthyroidism, I would call them thyrotoxicosis because they will come to your clinic with a suppressed TSH and IT3. Now, if there is a thyrotoxicosis, you need to do a technician scan and TRAB. The reason is if it is thyrotoxicosis, that is towards thyroiditis, and if you have got hyperthyroidism, the management is different. That is one to answer your first question. What was your another question?
What is the management of
Oh,
subclinical
yes. As I told
hyperthyroidism?
you, subclinical hypothyroidism to be treated in growing up children, adult with signs and symptoms, and in pregnancy. And treatment doesn't differ. You need a lower dose of levothyroxine. But you may always
And
do an anti-TPO to make sure that antibodies are um, okay.
sir, in clinical practice, many patients I find that they are not getting controlled only with levothyroxine. Now preparations are there with T4 plus T3. What is your opinion
I
regarding
just
those
told
preparations?
you that I have got some patient that was not responding to T4 alone, and I used them T3 also. But the numbers are few and far in between. There is no consensus to start this combination in patient in daily practice. There is also not any benefit in studies done that a combination therapy will do better. But in those patients in whom you are struggling, yes, you can use.
Then what to do, sir? What to
Sorry?
do? Suppose then what to do?
Yeah,
High
I told you
doses
that
of
if you have got somebody taking 300 to 400
yes,
microgram
yes.
of levothyroxine not coming down, then add Liorma or T3 tablets 5 milligram BD.
Okay, and it has a very short half life, so
Yeah,
T3 has to be given frequently.
you can give twice daily, and if it works and if you are right, then you'll find it
And
effect very quickly.
what is the role of T3 in clinical practice? Is there any definite role? Because it's a wastage of money, which I find.
Roll off.
T3
Yeah, I told you
in
that it is almost like an orphan drug, and orphan drug FDA uses for a very selective group of patients. What I'm saying is T3 usage is very restricted and niche users. It should not be a general use.
no, not the usage. I am telling about the test. For routine test, we many I find T3, T4 and TSH is fine. Why T3? Is
Yeah,
it not a wastage of
isolated,
money?
sometimes you can have isolated T3 thyrotoxicosis. So if you are investigating hyperthyroidism for the first time, it may be a good idea to do the entire spectrum. But after that, you can always do FT4 TSH. So you can have a condition called isolated T3 thyrotoxicosis.
Sir, one question, Dr. Das.
Yeah,
Addison's disease is associated with hyperthyroidism and also hypothyroidism, which is
yeah.
common.
What is that called? Smith syndrome or something. Yeah. It can be associated because if you see, why do you think they're associated? What is your guess?
Autoimmune disorder.
Yeah, the autoimmune it is
Autoimmune.
also type 1 diabetes. It is associated with vitiligo. So there may be an overlap. Yeah. Anybody else?
Sir, biochemistry, Dr. Das, biochemistry
Yes.
of factitious hyperthyroidism.
Yeah. See, what happens is that I used to see a lot of patient abroad where nurses used to take thyroid tablets to get slimmer. So that is another problem when you test them, when you do the scanning, and etc., they can mimic hyperthyroidism. So you'll have to be careful. Rule out the
Right.
background. Try to understand what the patient is having, and so that is a challenge. But I don't think I've faced much of this factitious hypothyroidism in my country. But you have to be very careful in that, because if you take, it will present like a thyrotoxicosis,
Sir, amiodarone can cause both hyper and
both hyper and
hypothyroidism.
hypo.
The how?
And in
What is
hyper, it
the
can produce two types, type A and
yes?
type B. It
What
can
is the
produce,
commonest pattern? What is the
yeah,
commonest
hypo
pattern of
is
amiodarone?
easy to tackle. Hypo is
Right.
easy to tackle. It is
Right.
the hyper which is difficult to tackle most of the time. So, but yes, it can. I don't like amiodarone in thyroid patients. I try to tell them, and also I don't like lithium in depressive patients,
Right.
because
Right.
both of them can cause a thyroid problem.
Thank you, sir.
Okay,
Thank you very much, Tirthankar sir. Very good to
okay,
hear. And
thank
if there
you.
will be any more questions to the aspirants, they are free to ask. And if there's, I think there should be no any more questions, then we should end the
I
session.
think I'll have to take exit because I'm starting another lecture in 10 minutes.
Yeah,
Okay,
Dr. Mujna, please.
Sir, one question, Dr. Das.
last one.
Yes,
Yeah,
yes. Whether Jaws Basedow disease or Graves disease is same?
you know, Joe Besdo disease is different. And what do you think is Joe Besdo disease? When you use,
In thyromegaly.
yeah, Joe Besdo is different, and hyperthyroidism is different. Now, these are the nomenclatures are more for, you can, of course, need to know this, but most important, how do you progress? The way you progress is, first you look at the biochemistry. Once you get the biochemistry done, then there are two very useful terms that we use. One is, if I correct it, Wolff-Chaikoff effect and the Joe Besdo phenomenon. They are related, and they cause temporary suppression of thyroid hormone. That can happen due to, if you treat, sometimes, before operation, we give Lugol's iodine to a patient to make the thyroid gland hard. So it's a temporary suppression. Although you are giving iodine in Lugol's, but it temporarily overruns the gland, and you get a Wolff-Chaikoff effect or Joe Besdo phenomenon. So that's what it's called. But then don't continue that; it will flare up as you go by.
Thank you, sir.
Thank you, thank you, thank you,
Thank you very much, Tirthankar sir. Thank you very much.
thank
And
you.
thank you for the aspirants for their very much patience and to listening to sir. Thank you very much. Once
Okay,
again.
okay. I'm
Thank you,
just
sir.
trying to see whether they are already online or not.
Yes, sir.
Okay. Thank you. Okay.
Thank you very much, sir.
Thank
Thank
you.
you.
Thank you.